Okay, so let's go on and talk about infections in the elderly. So, elderly patients may only generate a low-grade fever or actually not even generate a fever in the setting of an infection. Okay, so we often expect fevers to occur with infections, whether they're viral or bacterial. Older patients, because of their uh, weakening immune system and weakening ability to generate significant inflammation, may not generate a fever even though they have an infection. Okay, so in the elderly, symptoms can be very non-specific. They can come in with an infection, but really have non-specific symptoms such as weight loss, a headache, and very commonly confusion. Okay, so even a bladder infection um, can cause confusion in the elderly. What are some other manifestations? So, in the elderly of infection. So, definitely a sudden change in function, decreased ability to walk, or profound weakness is common in the elderly with very mild infections. Okay. Sudden change in mental status is another one. So, a patient that has, say, a skin infection or a bladder infection or a more significant infection, they often become confused. Okay, so older patients come in confused, and one of the things that we need to suspect is that they have an infection somewhere in the body. Okay, and uh, these symptoms can be the first indicator of an infection before a more specific symptom. Okay, so let's use the urinary system as an example. Uh, Somebody who comes in with painful urination, frequency of urination, maybe some back pain because they have a pyelonephritis, so they have flank pain. When you have a kidney infection, you get flank pain. That may not occur with elderly patients. They may just come in confused and weak as they're presenting symptoms. Okay, so nonspecific weakness and fatigue is very common in the elderly. And as I mentioned before, weight loss, lack of appetite, just very vague symptoms that don't really connect to any particular organ yet. Okay, so let's go on and talk about the phases of healing. Okay, and this is going to be uh, what we spoke about earlier. There's the initial inflammatory phase uh, where the injury is being addressed with inflammation. There's been bleeding into the area, so a fibrin clot, which is the end product of coagulation. You get a fibrin clot, or you could just call it a blood scab is really what it is, right? So the fibrin clot hardens into the area, uh, and that's the inflammatory phase that we've been talking about. The proliferative phase is the new tissue that's being produced. So the fibroblasts are very involved in this, right? They start to produce tremendous amounts of collagen to uh, start to fill in the damaged tissue. Okay. The maturation or remodeling phase is where the collagen is remodeled in the injured tissue. Okay, and so the wound repair cells are removed. So, for example, the neutrophils, the macrophages, they're no longer needed anymore. So some of those will undergo apoptosis, which is cell death, and the fibroblasts will be much more involved in the remodeling and making the tissue return to its normal function. Okay? If the tissue is severely damaged and the fibroblasts aren't able to return it to its initial um, uh, tissue, then that's where you're going to get a scar formation, right? So now some people actually develop what's called a keloid. And a keloid is where a wound is being repaired by the fibroblasts, but the fibroblasts continue to make more and more um, collagen. And so the wound doesn't go back to normal. This is actually much more common in black people where they've had, say, a skin laceration or an injury to their tissue, and the fibroblasts overproduce collagen, and they're left with what's called a hypertrophic scar. The fibroblasts just didn't know when to stop producing the collagen. Okay, so these are the phases: the inflammatory phase that we spoke about before, that results in a scab or a fibrin clot, followed by the proliferative phase, which is the formation of new tissue begins, and then finally the maturation stage, where the collagen is remodeled and adjusted to repair the wound back to its original state, if possible. And here we can see the wound healing on these images at the top left. So there's an initial injury to the tissue. There's blood that's leaked into the wound, and that forms a fibrin clot, followed by the inflammatory stage, where there's macrophages, neutrophils, and still the blood is there, right? And the fibroblasts are in the tissue as well. And that's the inflammation that we've spoken about throughout this module. Then there's the proliferative stage, where the fibroblasts are very active, producing collagen to repair the wound. And finally, the remodeling stage, where the tissue wants to be back to its original state. So there's a new epidermis here, and there's freshly produced and healed dermis, which is going to be the fibroblasts producing the collagen. Okay, so what are we referring to when we're talking about primary and secondary intention of a wound healing? So primary intention is where you have a wound and the wound is sutured back together, or the edges are brought back together, say with skin glue or what are called steri strips, just to keep the wound back together. Okay, that's primary intention. Okay, so the wound has been cleaned out, and either surgically after an operation, or say someone's had a laceration, the wound is repaired with sutures and brought back together. Okay, so that's primary intention. Secondary intention is often for larger wounds, which have even more tissue loss, and they can be left open to heal. And with secondary intention, the wound heals from the bottom up. Okay, so the fibroblasts will start producing collagen at the bottom of the wound, and it will gradually just fill the wound. Okay, so why would we leave a wound open? Well, say someone had surgery and it was stitched back together or stapled back together, the tissue, and then it broke open. A term that we refer to as dehiscence. Well, now that wound can't just simply be stitched back together, okay? That would run a very high risk of infection. So we will leave the wound open to heal by secondary intention. Okay, so those are the main ways that wounds are healed: primary intention or secondary intention. Okay, tertiary intention is really a contaminated wound that is cleansed and flushed out, but still left open until the wound is clear of infection, and then it could be potentially closed with primary intention. Okay, the most important ones here are the concept of primary and secondary intention. So what are some factors that are going to impact a patient's ability to heal a wound? So here are some systemic conditions that patients may be suffering with that are definitely going to impact the speed and the ability for the body to heal a wound. So kidney disease is definitely an important one. In renal disease, you're unable to excrete a lot of waste, and that waste stays in the bloodstream, and that's going to result in poor healing of tissue. Okay, so anybody who has renal failure and then has a wound, it's going to take much longer for the wound to repair itself because there's waste in the bloodstream. On top of that, in renal failure, you have anemia because you're not producing a lot of erythropoietin. So patients often are anemic. And if you're anemic, you can't bring as much oxygen to the wound to help with the healing and tissue repair. Liver diseases such as hepatitis or cirrhosis, the liver is responsible for making proteins to repair wounds. So without proper protein production, wounds are going to heal again very slowly. So someone who has cirrhosis is going to heal their wounds very slowly. Heart issues. Well, with heart issues, you can be hypoxemic, meaning low oxygen in the bloodstream, and the tissue can also have edema, especially if you have heart failure. And if you have swollen tissue already, and now you have a wound to it, the blood supply can't get there very easily because the blood has to go through all that swollen tissue to get to the wound to help heal it. Okay, so heart issues result in low oxygen in the blood and also tissue edema, making it difficult for the healing factors to get there. Lung diseases. So again, hypoxia at the wound site. So someone, say, with emphysema or COPD are often hypoxic, and due to the hypoxia, the wound will not receive as much oxygen, which is necessary for aerobic metabolism, and that's going to slow down the wound healing. Gastrointestinal tract. So lack of absorption of nutrients and vitamins can occur in many gastrointestinal tract diseases due to the inability of the gastrointestinal tract to absorb them. So conditions such as Crohn's disease or celiac disease, or say a pancreatic enzyme deficiency in the setting of pancreatic failure or pancreatitis, those patients will not be able to absorb the nutrients that the liver will require to make proteins to heal the wound. Okay, so the nutritional status of a patient will also impact wound healing. So whether the wound is from a surgery or it's from an injury, if a patient has poor nutritional status, they're likely going to have protein deficiencies, right? So they haven't been eating properly. They're unable to produce all the proteins that are required, and that's going to impair collagen formation, and they're likely vitamin deficient as well. And we know that vitamin C and vitamin A play a big role in tissue healing. So vitamin C is required in collagen synthesis, and if you're deficient in vitamin C, you have a condition called scurvy. Vitamin A is very important in the healing of epithelial tissues, such as the skin. So deficiencies in any one of these vitamins will delay wound healing. So anything that affects blood flow to an area or oxygen delivery to an area is going to impede wound healing. Okay, so if you have a wound on your leg and you have poor blood supply to your leg due to, say, diabetes, which can start to cause blockages of the arteries, well, you're going to have poor blood flow, which is where all the nutrients are coming from, and you're going to have poor oxygen delivery since the hemoglobin is unable to deliver the oxygen to the tissue. Okay. Wound dehiscence I mentioned in an above slide. That's where a wound has been closed and it has now opened up. Okay, it's dehisced, it's separated, and this can occur from weak tissue, such as from age. It can occur from poor wound healing in diabetics. Remember, diabetics have develop occlusions and blockages of their arteries and their capillaries. So they're at risk for poor wound healing and potentially wound dehiscence. An infection that's in the wound and the wound just won't heal. Well, if those staples or sutures are removed, the wound will just suddenly open back up. Okay. Obesity puts a lot of tension on wounds. So when stitches or sutures stay in for 7 to 10 days, it's not fully repaired yet. It's repaired enough to usually remove the sutures or the staples, but someone who's obese is going to put more tension on that wound, and it can definitely lead to wound dehiscence. Cigarette smoking, that's a blood vessel problem, so there's going to be less oxygen getting to the area, and also smoking tends to occlude and block your blood vessels, your arteries, your capillaries. So poor oxygen delivery. And of course, inadequate nutrition that I mentioned before. The fibroblasts can't make the collagen, so the wound can potentially just open back up. Okay. Wound infection. So that can occur from very dirty wounds. It can occur from having left a foreign object in the wound. So say, for example, some soil or debris wasn't properly cleaned out. That is a high risk for developing a wound infection. Steroid use. So if someone's on a steroid, such as prednisone orally, that is a big risk factor for poor wound healing because steroids inhibit the inflammatory process, and you need the inflammatory process to heal the wound. Okay, that's an important one to remember. Patients on steroids have very poor wound healing, and actually they're immunosuppressed as well. Okay, So anybody, in fact, who's immunocompromised, has low white blood cells, or is anemic, is going to heal wounds much more slowly. Okay. And lastly, poor wound care. So if a wound isn't cared for properly with proper dressing changes, um, that will put the patient at risk for developing a wound infection. Okay? So foreign objects, the use of steroids, dirty wounds, anyone who's immunocompromised is at risk for getting a wound infection. So how can we classify wounds? Well, we can classify it by, say, the cause of the wound. So surgical wounds versus non-surgical wounds. The depth of the wound. Is it a superficial wound? Is it a partial thickness wound that's gone into the dermis? Or is it a full thickness wound that's gone through the epidermis and the dermis and into the subcutaneous tissue and possibly even the muscles and the nerves underneath? We can also classify wounds by their appearance. A wound that has a nice red, pinkish color is reassuring. It means that the inflammation is occurring and there's wound healing taking place. A yellow appearing wound or yellow discharge is usually an indication of an infection. A white appearing wound, say someone's had stitches put in and the stitches are just way too tight, the wound will appear white because the blood can't get to it because of the tight sutures. And it's ischemic. It's not getting the blood supply, right? And then finally, a black appearing wound, that's dead tissue, right? So that's necrotic tissue. Okay, so that's the end of this module. I think if you have a really good feel for this module, you'll find that the next module on immunity will be very straightforward. There's definitely more information to build on, but we spent a lot of time talking about the acute inflammation, the innate immune system versus the adaptive immune system. And in the next module, we're going to build on that and use examples so that it all fits in together. So see you at the next module.